Muy buenas noches a todos, bienvenidos de nuevo a una nueva sesión del Diplomado Internacional en Neurología Veterinaria. Recuerden que la clase de hoy va a ser en inglés, así que los que lo quieran escuchar en español tienen que cambiar la interpretación a español. Hoy comenzamos con el octavo módulo, que es sobre neuropatías, y vamos a tener el honor de presentar al doctor Paul Freeman, que nos va a estar hablando sobre enfermedad del disco intervertebral. La clase de hoy puntualmente va a ser sobre fisiopatología y clasificación de la enfermedad de disco intervertebral. Y la siguiente ya va a ser sobre aproximación diagnóstica y tratamiento. Lo digo para que lo tengan en cuenta en el momento de hacer las preguntas sobre todo. Bueno, el doctor Paul Freeman se licenció en Cambridge en 1987 y después pasó 6 años en una consulta mixta en Yorkshire y Suffolk. En 1993 obtuvo el certificado del Royal College of Veterinary Surgeons en ortopedia de pequeños animales y pasó a desarrollar un centro de referencia para ortopedia y neurología en su condado natal en Essex. Paul obtuvo el diploma europeo en neurología veterinaria en 2014 y en 2016 asumió su puesto actual de neurólogo clínico principal en el Queen's Veterinary School Hospital en el Departamento de Medicina Veterinaria. El servicio de neurología creció rápidamente en los últimos años y actualmente emplea a 3 neurólogos especialistas, así como un residente en formación y a un interno del servicio. Las principales áreas de interés de Paul siguen siendo el manejo de la lesión de médula espinal canina, específicamente la enfermedad de disco intervertebral, y ha publicado artículos de revisión en 2017 y 2018 sobre el papel de la fenestración del disco intervertebral. A pesar de tener un papel principal clínico, Paul se las arregla para combinar los intereses de investigación y enseñanza con la carga de casos en constante aumento en el hospital. Paul ha impartido numerosas conferencias tanto a nivel nacional como internacional y disfruta enormemente del aspecto docente de su función actual y de su implicación con estudiantes y residentes de veterinaria, así como de su trabajo en un equipo de especialistas experimentados. Dr. Paul, welcome.
Muchas gracias, Esteban.
Okay, you can share your screen and the auditory is all yours.
Okay. Okay, well, good evening, everybody in Europe. Buenas tardes if you are in South America. Thank you for joining this first of two webinars on my favorite subject, which is intervertebral disc disease in dogs. I'm going to share with you some things that we have been working on in Cambridge, some of the pathophysiology, some of the underlying problems that lead to disc disease, and try to enable, hopefully, a better understanding of this very, very common disease. What I'm hoping you will get from the lecture today is a little bit of an understanding of the anatomy of the disc and the process that's involved in disc degeneration and disc disease. And we're going to cover the different categories of intervertebral disc disease, the classification of disc disease, hopefully to leave you with a better understanding of the different types of disc disease that we see. So to begin, I'm just going to move my screen a little bit, or try to. Bear with me for a second. That's better. So I can see the whole screen. So what is intervertebral disc disease? Well, this is a very basic beginning. And I wanted just to show you a little bit of the anatomy. The Dachshund is the breed that is probably most commonly affected with intervertebral disc disease, certainly in the UK where I work. What we're talking about is disease associated with these little shock-absorbing structures, the intervertebral discs that lie in between all of the vertebrae, all the way down the spine from the top of the neck all the way down through the tail. And in fact, it is even possible to get disease in the tail itself. But we're focusing mainly on this area, the thoracolumbar region, and also the cervical region, the neck, which is where we most commonly see disease in our discs. So a little bit about the anatomy. The disc, as I'm sure you know, is made up of primarily two distinct parts. That's the outer annulus fibrosus and the inner gelatinous nucleus pulposus. The annulus can be likened to a radial car tire. It's made up of layers of collagen fibers arranged as lamellae, and it forms this tough fibrous outer ring that encases the inner softer gelatinous high water content nucleus pulposus. Important thing to understand is that this disc is firmly embedded between adjacent vertebrae. We talk in England, we talk about a slipped disc. I don't know if that's an expression that you are familiar with, but in the UK, people talk about a slipped disc. And our owners, our dog owners, often imagine, and I think we sometimes imagine, that the disc can actually move in and out between the vertebrae. This is completely impossible. The disc is very, very firmly attached via these cartilaginous end plates, which really fuse the disc into the vertebra, the adjacent vertebral body. And so it's better to think of this as a complete structure from vertebral body, vertebral end plate, cartilaginous disc end plate, then the disc itself, and then the same thing on the other side. And that's really a better way of thinking about the structure of the disc. I like to use this analogy of the jam or jelly donut, which is this cake that we have here, and I know they have in the US. Our discs are a little bit like that. And this is a useful analogy when explaining disc disease to owners, because I talk about the annulus being the outer casing of the donut and the nucleus being the inner jelly component, and explain to people how the jelly can leak out through a hole in the annulus and cause damage to the spinal cord. And it's just a useful analogy for people, helps them to understand the disease a little better. Very important to understand the anatomical relationship of the disc with the spinal cord, because when we see disease associated with the disc, we're talking about myelopathy, we're talking about disease of the spinal cord and damage to the spinal cord. And the reason is that the disc is intimately associated with the vertebral canal, which contains the spinal cord, sitting immediately above. So the dorsal part of the annulus forms the floor of the vertebral canal here. And the spinal cord, obviously, surrounded by the meninges and the cerebrospinal fluid, sits immediately dorsal in our dogs to the intervertebral disc. So problems associated with the disc inevitably can lead to inflammation and damage to the spinal cord sitting adjacent. In a healthy disc, the nucleus pulposus is a gelatinous mass which consists of 80% water. The principal cellular content is notochordal cells. The nucleus is derived from the notochord embryologically. And the extracellular matrix is rich in glycosaminoglycans, high molecular weight proteoglycans, and collagen type 2 fibers. And it's that mixture of collagen type 2 and high molecular weight proteoglycans and glycosaminoglycans that creates a high osmotic pressure and means that the nucleus pulposus is able to maintain a significantly high water content. And that's what gives it its gelatinous structure. It's what allows it to function as a shock absorbing structure in between the vertebral bodies. Intervertebral disc degeneration has long been known to be associated with disc disease. And I'm sure many of you will be aware of the famous treatise by Hansen in the 1950s, where he described disc degeneration and characterized these two distinct categories of disc degeneration. Hansen described a process of chondroid degeneration leading to disc calcification in chondrodystrophic breeds of dogs. And chondrodystrophic breeds are those breeds that are associated with short legs, almost like dwarfism. So classically the Dachshund, but nowadays also the French Bulldog is a very common example of chondrodystrophic dogs. The non-chondrodystrophic breeds, Hansen described this process of fibroid degeneration, leading to a fibrous, thickened disc, not calcified. And for many, many years, this understanding of two types of degeneration leading to two different types of disc disease was very much the belief and the focus. More recently, that's been called into question by work done in Utrecht. And I will come on to that in another slide. But just to say that we now believe the degenerative process is a little bit more overlapping and not so distinctly separated between chondrodystrophic and non-chondrodystrophic dogs. And what happens during disc degeneration is that the gelatinous mass and the water content is reduced. The notochordal cells are replaced primarily by chondrocyte-like cells. The glycosaminoglycan content is reduced, and the collagen type 2 fibers are largely replaced by collagen type 1. This leads to a reduction in osmotic pressure and ultimately to a dystrophic calcified disc. And this is the process of, if you like, Hansen's chondroid degeneration. I'm just putting these three papers, these references up for you, because this is the work I was talking about that has called into question a little bit. This paper by, interestingly, another Hansen entitled The Myth of Fibroid Degeneration. And they really have sort of questioned this separation between fibroid and chondroid degeneration. And I think most workers now believe that there is much more of an overlap in the way that discs degenerate. What is agreed across the board is that degeneration of the discs predisposes to disc disease of one form or another. And we'll come back to that. Just to give you a little bit on calcification. Calcification of the discs is a significant problem. Calcification itself is not a disease, or calcification, as far as we're aware, does not cause specific problems within the disc, but it definitely predisposes the disc to disease, to extrusion. And there is a strong association between disc calcification and disc extrusion. We've been looking at the process of calcification, trying to understand the process of calcification better. And we know that in other tissues in the body, calcification is associated with pro-inflammatory cytokines, with differentiation of osteoprogenitor cells, and ectopic ossification, leading to altered biomechanics in tissues that suffer calcification. In our intervertebral discs, we have identified, or there have been identified, various factors associated or potentially associated with calcification. The one that I'm most interested in is this one at the bottom, this poly-ADP ribose polymerase, which is an enzyme that has been associated with calcification in other tissues. And poly-ADP ribose polymerase, or PARP, we know that it's intimately involved in soft tissue calcification and disease in human tissues. It's been associated with various cancers as well in human medicine. We know that the product of PARP, which is PAR, poly-ADP ribose, is found close to the extracellular matrix, where developing bone and arteries are calcified. And it's produced in response to oxidative stress. And what PAR does is that it is able to attract in calcium ions along with hydrogen, oxygen, phosphate, and create a calcium hydroxyapatite material, which is, we believe, intimately involved in the calcification and is ultimately the end result of calcification. What's exciting about this, and I'm sorry to bore you with this biochemistry, but what's exciting about this is the activity of PARP can be inhibited. This has been shown in various human models that this enzyme can be inhibited by various factors, including an antibiotic called minocycline. And so if we are able, through our work, to show that this is a significant factor in the calcification of intervertebral discs, then we may be able to do something about inhibiting or disrupting the process of calcification. As I said before, calcification is associated with intervertebral disc extrusion. There are a number of papers that have shown a significant association between the number of calcified intervertebral discs and the likelihood of a dog suffering a disc extrusion. And so, although the identification of a calcified disc doesn't confirm disc disease or a disc extrusion, identifying multiple calcified discs or a calcified disc definitely increases the likelihood that disc disease is the cause of the problem that you're looking at. How does calcification affect disease? Why should calcification lead to disc extrusion? Well, calcified discs, obviously, intuitively, you would understand, change their biomechanics. So we're talking about a disc that initially has a high water content and can act as a nice shock absorber when an animal is moving in between the vertebrae. As that disc becomes calcified and loses its water content, it's going to become stiffer, it's going to become less able to cope with the stresses and the biomechanical issues associated with movement. And we suspect that that is what predisposes the disc to extrusion. What we know as well is that in human back pain, calcified discs are more likely to lead to a myelopathy and are also associated with back pain. X-rays can identify calcified discs. People often say that X-rays are not useful in disc disease. Well, I think that they can be useful. You just have to know how to take good X-rays, and you have to know how to interpret them. And I just want to show you one X-ray here where there are a number of disc calcifications that I think you can see. Probably this last one is the clearest one. Probably this one actually has some calcified material in it as well. So all of these discs contain some calcified material. It doesn't tell us that if we are presented with a dog showing signs of disc extrusion, we can't say which of these discs is the cause of that disc extrusion. But if we see an X-ray like this in a dog that has all the indications of disc extrusion, we can be just that little bit more certain that disc extrusion is the cause of that dog's signs. Just to finish off with the pathogenesis, there are a number of factors, as I've said already, that are involved. We think the calcification is a significant one. Changes in biomechanics probably are also involved, and there's probably a close link between calcification and changed biomechanical responses within the disc. We also know that there's a significant genetic predisposition, and I'm sure many of you will be aware that a few years ago now, there was a publication that showed that this FGF4 retrogene on chromosome 12 is closely associated with both the chondrodystrophic short-legged conformational structure of the dog, but also it's associated closely with disc extrusion. And we know that the presence of the FGF4 retrogene on chromosome 12 is a predisposing factor for disc disease, disc extrusion in chondrodystrophic dogs. It is possible to have a genetic test for FGF4 on chromosome 12, the so-called CDDY test. Unfortunately, what we know is that in a majority of breeds that seem to be associated or have a high frequency of disc disease, and particularly in the Dachshund, the FGF4 chromosome 12 is fixed. In other words, all the Dachshunds, certainly in the UK, pretty much that are tested, seem to have 2 pairs of this FGF4 chromosome 12. And so testing them and breeding away from this is just not possible while still preserving the breed. There is also an FGF4 retrogene on chromosome 18 that's been associated also with chondrodystrophy, but not associated with disc disease. And we in Cambridge are also doing further work looking at the genetics of disc disease, because we are pretty sure that there are going to be other factors as yet to be identified, which might be more useful in terms of breeding. So that's the pathophysiology, if you like, the boring bit, the difficult bit. Now we come on to the classification of different types of intervertebral disc disease. And this is where I think people can get very confused. And so hopefully I'm going to give you a clear picture, and I'm sure we'll have time for some questions at the end of this if anybody has them. So please feel free. I should have said at the beginning, please feel free to use the chat function or potentially speak at the end of the talk. So primarily, disc disease is divided into 2 types. That's the so-called protrusion, where the annulus fibrosus remains intact, but changes shape, bulging and protruding into the vertebral canal and causing compression of the overlying spinal cord. The other type of disc disease is what we call an extrusion. And an extrusion involves a rupture of the outer annulus fibrosus and an escape of nucleus pulposus material. And that nucleus pulposus may remain attached to the rest of the nucleus inside the disc, or more commonly extrudes in a more explosive way and spreads through the vertebral canal. And again, it can cause compression of the spinal cord, but it can also cause a contusion, a bruising of the spinal cord through its exploding into the vertebral canal. And so these are the 2 key types of disc disease. And then there are a number of variations, which I'm going to talk about now. But just keep in mind protrusion and extrusion. Protrusion where the annulus is intact, extrusion where the annulus ruptures. So this is the classification that has been given relatively recently in a paper in Frontiers by the Canine Spinal Cord Injury Consortium, Joe Fenn and Natasha Olby. They classified intervertebral disc disease into 7 different types. Firstly, there's the Hansen type 1 extrusion, which is the extrusion that's associated with calcification of the nucleus pulposus, seen mainly in chondrodystrophic breeds, and the most common type of disc disease that we see. They also sort of subclassified the Hansen type 1 extrusion to include this so-called extrusion with extensive epidural hemorrhage, which we'll talk about a little bit. Another type of extrusion where the extruded material actually invades the dura and even the parenchyma of the spinal cord, the so-called intradural intramedullary extrusion. Then we have two types of extrusion involving a non-degenerate, non-calcified nucleus pulposus. There's the so-called hydrated nucleus pulposus extrusion and the acute non-compressive nucleus pulposus extrusion. And we love our acronyms in neurology, so we call these the HNPE and the ANNPE. And these are both types of extrusion. So the annulus ruptures and there's escape of the nucleus, but the nucleus is non-degenerate in these cases. And I'll describe these to you and the differences in them. And then we have the so-called traumatic disc extrusion, which they created a separate category for, which is, again, a disc extrusion, so rupture of the annulus and escape of the nucleus, but this is associated with some kind of external trauma. And these cases are seen often associated with road traffic accidents or polytrauma. And then finally, there's the Hansen type 2 protrusion, which is where the annulus remains intact, but bulges into the vertebral canal, causing compression of the spinal cord. So now we'll just talk through each of these individually and try and give you some characteristics of each one. So the Hansen type 1 intervertebral disc extrusion, and this is the most common one. This is the one that we're generally most concerned with, the one that causes us the most problems and perhaps controversies. And this is where we have a calcified nucleus pulposus breaking through that outer annulus fibrosus, usually dorsally, sometimes a little bit more lateralized, and breaking through into the vertebral canal. As I said, it's the most common type of disc disease that we see. It's associated with this chondroid degeneration and calcification of the nucleus pulposus and rupture of the annulus fibrosus. And you get herniation of this degenerate calcified nucleus pulposus material, as you can see on the picture on the bottom right, this chalky calcified material compressing the spinal cord overlying it and creating sometimes hemorrhage, inflammation, and obviously, intuitively, you would say causing damage to the spinal cord. And the type of damage that this disease causes to the spine is very much a mixture of both contusion, which is effectively a bruising and edema of the spinal cord, and a compression. So when this nuclear material escapes through the hole in the annulus, it can rupture in a very explosive way, or it can escape in a very slow, gentle way. And so there's a huge variation in the degree of contusive injury and compressive injury associated with this type of disc extrusion. And what we see in the vertebral canal is very much a mixture of hemorrhage, calcified material, bits of annulus, and all of this going on inside the vertebral canal. The most common signalment is, as I said already, chondrodystrophic breeds of dog. The median age that we see this is around 5 years, but it can occur from a year of age. There's a wide range of clinical presentations and severity associated with this, all the way from mild self-resolving back pain through to permanent and irreversible paraplegia, paralysis associated with complete spinal cord injury. So it really does give a huge variation in symptoms. When we talk about the age, just to give you some idea from work that we've done, what we find is that in the French Bulldog, we see this much younger, so 2-3 years of age, very commonly. In the Dachshund, they're usually around about 5 years of age. And then the Cocker Spaniel, another very common breed that we see this type of disc extrusion they tend to get their extrusions much older, around about or median of about 8 years. The onset of signs is usually quite acute, often progressive over a few days, and there's usually significant pain associated with this type of extrusion. Depending on the location, obviously it may be thoracolumbar pain or cervical neck pain, but often and usually these extrusions cause significant pain. When you do your neuro exam, you should be able to localize these lesions to a focal lesion in the spinal cord, and we'll talk about this more in the second lecture next week. And if you take survey radiographs, you'll often see a narrowed intervertebral disc space. One of the things that I'm very keen to share is that I've got MRI pictures here for you, and you can see these extrusions on the MRI. This is this big black extrusion here. This is the disc. This is the spinal cord, and this is the extruded disc material. Here's the disc on this sagittal view. Here's the extruded disc material. Here's the spinal cord. Obviously, to make a firm diagnosis of this type of disease, we do need advanced imaging. We need MRI or CT, generally speaking. But I'm aware that there are many people in many different situations for whom obtaining this type of imaging is just not possible. And so I want to hopefully share with you ways of being pretty confident about your diagnosis without necessarily having an MRI or a CT. As I say, most of that will come in the second part of these two lectures next week. But it is worth bearing in mind that taking a plain X-ray, identification of calcified discs, narrowed intervertebral disc space in a region where you suspect the problem to be located is definitely helpful in terms of narrowing your differential diagnoses. Just to talk a little bit about this so-called extrusion with extensive epidural hemorrhage, and I give you a paper here that has been published. There were a number of papers published in the last couple of years about this apparently new type of extrusion. I have to say, I'm a little bit I have a feeling that we're almost creating something artificial here. We know that some type 1 extrusions have a significant component of hemorrhage. They create bleeding as the material breaks through into the vertebral canal. You can have bleeding from the vertebral venous sinuses. And people have put together case series showing, particularly in French bulldogs, often there's a significant component of hemorrhage. And the suggestion is that these cases are more likely to be more severe. So in other words, to present non-ambulatory, to be more acute, to be progressing more rapidly. And the suggestion is that maybe these cases require more urgent attention and surgical decompression. My personal opinion is that this is not true, and that all of these cases can be managed in a similar way to what we will talk about next week with standard management for type 1 disc extrusions. And I'm going to tell you, I'll tell you now, I'm going to tell you again next week that I do not consider these to be surgical emergencies, unlike many people and many of my colleagues, I have to say. I feel quite strongly that these cases are not, in fact, surgical emergencies, and I'll talk more about that next week. The intradural intramedullary extrusion, this is where the extruded material actually penetrates the outer tough dura of the spinal cord and maybe even embeds in the spinal cord parenchyma. These cases are rare, and we don't see them very often. In order to diagnose them, you do need good quality MRI, or preferably perhaps even CT myelography might be a better way of diagnosing the intradural extrusion. Most reported cases are thoracolumbar. There's a paper here that I give you for those who are interested, reporting a small case series of intradural, intramedullary extrusions. And they understandably can cause quite significant spinal cord injury, spinal cord damage. Whether or not they are more urgent surgical cases, again, I think is open to debate. But it's just really something to be aware of, that it is possible for an extrusion to actually penetrate the dura mater. The traumatic disc extrusion, again, I guess probably many of us will have seen disc extrusions associated with external trauma. So an animal falling from a height or being involved in a road accident. Usually there's an association with polytrauma. So there are often other factors that need to be considered before we start to consider the disc extrusion. So, for instance, breathing difficulties, trauma to the chest, bleeding in the abdomen, those kind of things which do need to be dealt with more urgently. But it is worth bearing in mind when you're faced with an animal that's been involved in some kind of external trauma, that a disc extrusion may have occurred. So if you are faced with unexpected or unexplained neurological signs, paraplegia or paraparesis, which can't be explained by a spinal fracture, for instance, that it may be that a traumatic disc extrusion has occurred. Obviously, the signs are generally going to be peracute in onset and generally quite severe. The disc may be degenerate, may be a calcified type 1 extrusion, or it may be non-degenerate, similar to the so-called ANNPE, which we're going to talk about very shortly. And diagnosis and treatment will obviously be dependent on severity and other associated problems. So that leads us on to the Hansen type 2 protrusion. And this is where we have a thickening and a bulging of the degenerate annulus fibrosus. This type of disease is associated with disc degeneration. It was more associated by the original Hansen with the so-called fibroid degeneration. We now know that you can see these protrusions in both chondrodystrophic and non-chondrodystrophic dogs. But we do see them more associated with large breed, older, non-chondrodystrophic breeds. There's no escape of nucleus pulposus. This is the only type of disc disease where the nucleus pulposus remains inside the intact annulus fibrosus. And so a majority of the spinal cord damage, spinal cord injury in this type of disease is caused by compression. There are many, many variations possible. Again, we see these disc protrusions all through the spine. They are, again, more common in certain regions, again, the thoracolumbar region, but we also see them in the neck. We see them in the caudal cervical region associated with wobbler syndrome. We see them at the lumbosacral region associated with degenerative lumbosacral stenosis. We also commonly find these as an asymptomatic incidental finding. And so understanding whether something like this is the cause of our symptoms can be difficult. In this MRI, there are probably 3 protrusions, maybe 4 visible. The biggest one, this one here. But this is a common scenario for us where we're perhaps imaging a dog that shows a T3L3 localization, paraparesis, a myelopathy, and we suspect disc disease. We do our imaging and maybe we'll find multiple disc protrusions, and we have to decide which is the most likely to be the cause of the problem, particularly if we're going to consider surgical treatment. And this can be quite problematic. These discs are variably painful. Some of them can be painful, but many of them are relatively non-painful, in fact. The signs that you see tend to be chronic and progressive. So these tend to be slowly progressive. They tend to get worse with time. As I said already, it's usually our larger non-chondrodystrophic breeds, breeds such as the German Shepherd, Labrador, Dalmatian, Doberman. These type of dogs are very prone to disc protrusions. Another complicating factor, other than the fact that we often have more than one protrusion present, and some of these protrusions are asymptomatic, many of these dogs have other comorbidities, things like degenerative myelopathy, osteoarthritis, cruciate ligament disease, and it can be very difficult to separate out these types of problem and work out what is the primary cause of our dog's symptoms. The prognosis for these cases is a little uncertain. They are much more difficult cases than our extrusions. And I do sometimes advocate use of prednisolone, a steroid trial in these cases. We'll talk more about treatment again next week, but steroids can sometimes help these dogs. And there is definitely evidence that surgery is more effective than medical treatment in these cases. Now we come on to these two sort of more per acute types of extrusion. And these are extrusions of a non-degenerate nucleus pulposus. So the first one is the so-called hydrated nucleus pulposus extrusion. And this is where we have rupture of the annulus fibrosus and herniation of non or partially degenerate nucleus pulposus. And what we see is a focal accumulation of non-degenerate nucleus pulposus over a disc. Often the nucleus pulposus will be reduced in volume on the MRI, and we see this compressive lesion on a transverse. Sometimes these are likened to a seagull sign, and they've also been called or compared to spinal cysts. And basically, we have a compressive lesion caused by a highly fluid nucleus pulposus. They were first described in the cervical region, but they have since been shown to occur in the thoracolumbar region as well. They're often associated with vigorous exercise or some kind of mild trauma, and they sometimes develop in signs over a couple of days. The other one, which is very similar, is the so-called acute non-compressive nucleus pulposus extrusion, which similarly involves rupture of the annulus fibrosus and escape of non-degenerate fluid nucleus pulposus. The difference here is that there is no compression of the spinal cord. This is a purely contusive lesion, and you can see this little hyperintense lesion within the parenchyma of the spinal cord, which indicates where the escaped nucleus pulposus has created edema and contusive injury to the spinal cord. Both of these tend to have a relatively acute or per acute onset of signs. The hydrated nucleus pulposus extrusion can be progressive over a day or two. I've certainly seen these dogs progress over 24 hours, whereas the ANNPEs tend to present with per acute onset of signs that often start to improve quite quickly. We see them mainly in middle-aged and older dogs, but again, any age of adult dog can be affected, and perhaps border collies in some studies are overrepresented. You should again be able to do a neuroanatomical localization to a focal spinal cord lesion in a particular region of the spinal cord. The ANNPE often presents with markedly asymmetrical signs, whereas the HNPE, the symptoms are usually more symmetrical. HNPE, more common in the cervical region. Usually they are minimally or non-painful by the time they're presented. The history often, the owners will report that the dog cried out when the signs initially started, often associated with chasing a ball, catching a frisbee, that kind of exercise. Again, the HNPE can present with pain. A lot of these do have more persistent pain, perhaps associated with the slight compression that they cause of the spinal cord. As I said, they often occur during vigorous exercise like ball chasing. The prognosis is good in pretty much all of these cases, particularly if pain sensation in the feet and spinal reflexes are preserved. Treatment is primarily medical. Certainly for the ANNPE, treatment is purely medical. For the HNPE, there are described surgical cases, and I've certainly operated on these cases in the past where the animal seems to be progressing rapidly, and we don't like to leave them. But the evidence is that they do just as well with medical treatment as they do with surgery. The major differential is a fibrocartilaginous embolism, the so-called FCE, although this generally is not associated with exercise or trauma, and it doesn't really matter, to be honest. Differentiating between an ANNPE and an FCE is not really important because the treatment, in other words, just rehabilitation, is the same. The main differential that is important is the Hansen type 1 extrusion. But what we find is that these are usually less acute. They are often progressing over a few days and always more painful. The acute traumatic extrusion that we mentioned is definitely a form of ANNPE, or the ANNPE is a form of acute traumatic extrusion. So this is where I feel these categories tend to overlap a little bit and it can become unnecessarily complicated. Just a word on spinal cord injury. Again, just to reiterate, the primary spinal cord injury that's associated with all of these types of disc disease will be a mixture, generally, of contusion and compression. And contusion caused by escape of nucleus pulposus material, whether that's degenerate calcified material or non-degenerate fluid material. And compression, whether that's caused by persistent extruded nuclear material, calcified material, or hemorrhage, or a bulging of the annulus. Once you have a primary injury, particularly an injury that is associated with contusion, there will be a cascade of secondary events occurring, which can go on for hours or even days. And many people have looked at ways of trying to interrupt or prevent or reduce this so-called secondary cascade of events associated with ischemia, inflammation, and ultimately leading to gliosis and cystic cavities in the spinal cord. But up to now, nobody has shown any treatment that can actually intervene with the secondary spinal cord injury. So all of our treatments really are aimed at dealing with primarily the compressive injury. The compression is the only one we really have ways of dealing with. So I just want to summarize for you some of the nomenclature and classification around disc disease, because I feel this can get very complicated, and I'd like to try and leave you with as clear as possible a picture of the different types of disc disease before we come back next week to the diagnosis and treatment of these different types of disc disease. So just to summarize a few facts for you. Degeneration of the disc predisposes to disease. Degeneration is a process that occurs in a vast majority of dogs and some cats. It's a process that occurs at different rates in different breeds of dog. In certain types of dog, degeneration ultimately ends up with calcification, sometimes significant calcification. And degeneration predisposes to disease, whether that be Hansen type 1 extrusion, or Hansen type 2 protrusion. Calcification is an extreme form of degeneration, and it's seen mainly in the chondrodystrophic breeds. It can occur very young. When I say it's an extreme form of degeneration, I don't mean that it takes years to occur. We see calcification in Dachshunds at a year old and probably even younger. And it's definitely an extreme form of degeneration, and it doesn't always lead to disc extrusion, but it's known to be a predisposing factor. So again, to clear up some confusion, if you see a calcified disc, it doesn't mean that that disc will inevitably extrude. But what we do know is that dogs that have more calcified discs are more likely to suffer an extrusion at some point in their life. And we know that most of the Hansen type 1 extrusions will occur in calcified discs. Most type 2 protrusions, on the other hand, will occur in non-calcified discs because calcification does not predispose to protrusion. We also know that non-degenerate discs can extrude. So non-degenerate discs can rupture for various reasons, whether that's associated with trauma or not. And you can get escape leakage of a non-degenerate nucleus pulposus, leading to either pure contusion or, in the case of the HNPE, a little bit of compression of the spinal cord. And just finally, before I close and offer you the chance to ask any questions, I'm going to summarize what I think are the four most important types of disc disease for you. The most common, the most frequently seen, the one that we'll talk most about next week, the Hansen type 1 disc extrusion. These are the things to remember. It's associated with disc calcification. We mainly see it in young or middle-aged chondrodystrophic breeds of dog. 70% of these cases occur in the thoracolumbar region and roughly a third in the cervical region. Signs are usually acute and progressive over a few days. It's painful, very painful, and these dogs do need treating with good quality analgesia. Spinal cord injury in these cases is caused by a mixture of contusion and compression. And it is the most common cause of spinal cord injury in dogs. If you are presented with a dog that fits this picture, then it probably is a Hansen type 1 extrusion. We do see it in cats, but it's much less common than it is in dogs. Hansen type 2 protrusion, no association with calcification in this case. Mainly we see it in middle-aged and older, large breed, non-chondrodystrophic dogs, as we already spoke about. Signs tend to be chronic and progressive, and it's variably painful. Often these dogs are not obviously painful. It's significantly associated with a couple of relatively common syndromes. That's the cervical spondylomyelopathy or wobbler syndrome and degenerative lumbosacral stenosis. There are other factors involved in these conditions. They are not purely disc protrusions, but disc protrusion tends to form a significant part of both of these two conditions. Spinal cord injury in this type of disease is mainly caused by compression, but we do see some contusion as a result of repeated concussion and often instability, particularly in the wobbler dogs and the lumbosacral dogs. The hydrated nucleus pulposus extrusion. Breeds that are affected by this and the age that you see it can be very variable. It can occur in adult dogs of both chondrodystrophic and non-chondrodystrophic breeds. Most case series that are published report an age range of anywhere between 2 and 12 years. Cervical location is more common than thoracolumbar. Signs tend to be acute or peracute in onset, but maybe progressing definitely over the first 24 and maybe as long as 48 hours. Onset of signs is often associated with activity and vigorous activity. And these cases often are painful when you examine them. Perhaps not as painful as the acute Hansen type 1, but definitely more painful than the ANNPE or the FCE, fibrocartilage embolism. Spinal cord injury in these cases is caused by, again, a mixture of compression and contusion. And then lastly, the ANNPE or the acute non-compressive nucleus pulposus extrusion. Again, adult dogs of any breed, more common in larger non-chondrodystrophic dogs. Always a per-acute onset of signs. Usually the signs are static or improving by the time we see these cases. They're nearly always non-painful, although owners will often report pain at the immediate onset of signs. Often the signs can be asymmetrical, similar to a fibrocartilaginous embolism, and the spinal cord injury in these cases is caused by pure contusion. It's easily confused with a fibrocartilaginous embolism, but does that matter? Answer, no, it doesn't matter. And that's the end of this evening or this afternoon's presentation. And this is just a taster of what's to come next week. For those of you that are planning to join, we're going to look at much more clinical aspects, the diagnostic approach to intervertebral disc disease and the treatment options that are available. And we'll talk again a little bit about signalment history, how you can use clinical reasoning to achieve a diagnosis. We'll talk about the neuro exam in these cases. We'll talk a bit about the imaging, and I'll try and pull together for you how you can achieve a diagnosis, perhaps with or without advanced imaging. And I'll also talk to you about the treatment options and particularly focus on perhaps the non-surgical options, but I will cover the surgical treatments, particularly for type 1 and type 2 Hansen disease and prognosis. So hopefully some of you will be able to join that. And I don't know how much time we have for questions, but I'm happy to take any questions now if anyone watching currently has questions. Hi.
Hi, Doctor. Thank you very much for that amazing lecture. We have just one question for now. I think maybe tonight we're going to let you breathe until next week.
No problem.
The question, I think you're going to answer this in the next class, but
Yes.
the doctor is asking if there is no recommendation of surgical options in the disc protrusions, particularly about the corpectomy.
Yeah. I will answer that next week. My short answer is that surgical treatment for disc protrusions, I think when other factors are taken into consideration, surgery generally is the best option for these cases. And if we're going to do surgery on a thoracolumbar protrusion, then I think the corpectomy is the best approach. Absolutely. Yeah.
Okay.
But we'll talk about that a little more next week.
Okay. Okay, so I think that's all because we don't have any more questions.
No problem. Good.
So we see you next week.
Yeah, perfect. Okay, thank you very much.
Okay, thank you very much. Good night.
Bye-bye.
Bueno, la próxima conferencia va a ser de nuevo, va a estar dada por el doctor Paul Freeman y va a estar hablando de enfermedad de disco intervertebral, aproximación diagnóstica y tratamiento. Buenas noches a todos.